Slides as well?
Yeah, we can see them.
Perfect. All right, well, thank you so much for having me here today. It's my pleasure to be able to talk to you about some of our experiences from the Mass General in regards to the COVID-19 pandemic. As mentioned, I'm an anesthesiologist and ICU intensivist here at Mass General. And during normal times, I split my time and I'm also the director of orthopedic anesthesia. And now in these pandemic times, I'm also the director of one of our, what we call our surge ICUs, or the ICUs that we've created de novo with the ongoing pandemic. The goals for today are to go over some of the PPE and kind of practical OR and ICU management of, that goes along with treating patients with COVID. I'll go into some of the epidemiology and pathology. I think we can all read quite a bit in the literature about this, so I'll try to hit some of the highlights and more of the kind of practical realities of what the epidemiology and pathology dictate as pertains to the management, especially in the ICU. I'll touch on a couple of the potential therapies, and then I'll spend the bulk of my time talking about kind of some of the lessons learned from our use of anesthesia machines to take care of these patients, and what it's like to expand the ICU coverage beyond what any of us thought that we ever would. And then we'll have some time to recap and hopefully have some questions and answer period as well. So let's get into things. So when we talk about whether it's either OR management or ICU management, the major issue that we're dealing with COVID is that you really want to limit exposure of your patients and your staff. And we do this through really strict PPE and making sure that we have enough PPE to get around to the general care floors. So just to give you an idea of what the OR situation is like here at the MGH, during normal times, we have over 75 operating rooms, plus another about 25 to 45 out of OR areas that are being used daily to deliver anesthesia. And we've ramped that down pretty considerably. So we're down to about 10 ORs a day. So what this means is that we really only are doing the urgent and emergent cases that need to be done, and are deferring a lot of the routine care cases that we normally would be doing. This includes even cancer cases. You know, we have a committee that determines what type of cases we can do each day. And the goal here is to really limit exposure. With the testing for COVID, just about everyone is assumed to have been exposed when they come into our ORs. And this is, of course, of great importance when we talk about our off-site anesthesia locations. Things like interventional radiology, the cath lab, electrophysiology lab, endoscopy, and of course our obstetric population. They haven't gone away and they still have needs. So we need to make sure that we take care of them as safely as possible. And so best practices here, both at MGH in the US, is to use an N95 respirator and full PPE for every aerosolizing procedure. And when we talk about aerosolizing procedures, we specifically mean intubations, extubations, any type of surgery involving the airway, whether that be bronchoscopy or any interventional pulmonology or thoracic surgeries. And because of this, you burn through a bunch of PPE. If everyone in the room wears an N95, gown, mask, face shield during a case, that's a lot of people in the OR. And so when you talk about our model of anesthesia here, we have attending anesthesiologists, we have CRNAs, they're nurse anesthetists that help us out. We have resident anesthesiologists. We have, of course, a whole bunch of nurses that are in the room, and then our surgical staff. And so this ends up becoming quite an issue with usage of PPE, personal protective equipment, and N95s. And so we have developed a model where actually we try to limit the number of people inside the operating room at the beginning of the cases. And because of the air turnover in our operating rooms, we clear for at least 30 minutes after intubation, and that clears all the aerosols. And so the rest of the team can come in wearing more standard surgical equipment for the case. And this has cut down drastically on our PPE usage. We've also developed a pathway to recycle our N95 masks, so they get taken and are sterilized. So most of us have several N95s in the process of being sterilized and returned to us at any given time. And really, it's, these best practices and safety is of the utmost importance. What we've learned from both Wuhan and the Italian groups is that really your biggest commodity during these pandemic times are your people. And if we start to have anesthesiologists and intensivists get sick with COVID, that creates a lot more stress on the system. And so what we've developed are a bunch of these signs, best practices, and we actually have movies that we require everyone to watch, talking about putting on the personal protective equipment and taking it off. And really the hallmark of this is a buddy or a monitoring system. So as we put on all of our personal protective equipment, we have somebody who watches us, who can stop us if we miss any of the steps or don't have good coverage. And you can see the steps here. I won't go through all of them right now, but of greatest importance is making sure that we have the N95 surgical gown, full face shield, and gloves. And for most of our operating room procedures, we actually do a double glove so that we can remove the first set of gloves after intubation to try to limit the spread through all of our anesthesia equipment. And then we do the same thing when we take off our personal protective equipment. It's of course very important. You now have aerosol and respiratory particles that are covering your entire body when you intubate or extubate a patient. And so we want to make sure that you take off that gear properly so that you don't contaminate yourself or others going forward. We've developed some best practices pathways for our intubation, and this is, we call it our operating room intubation pathway, but we really use very similar strategies for our ICU patients, and I'll talk about this in a little bit more detail further on. But really, it's all about preparation. And so as often as you can, taking your time, making sure that everyone has clearly defined roles, and then making sure that you limit the amount of exposure to respiratory particles is most important. So we do all of our inductions in rapid sequence intubation methodology, and we try to avoid masking if at all possible so that you limit the respiratory particles that are delivered. We also use video laryngoscopy for all of our intubations. This gives you a direct view of the airway and also allows you to stand back from the airway so that you don't have nearly as much respiratory particles get onto you during this time. It's a luxury that we have here at Mass General in the US that we do have a lot of video laryngoscopy scopes around. And so I know that that can be quite a limitation for a lot of areas of the world. And so there's been some projects that I'll talk about in a few slides on how to work and limit some of the exposure during intubations. And then we do the same thing for our extubation pathway, and it's really about minimizing the number of people exposed and limiting the exposure of those people that need to be in the room. When we talk about aerosolization and respiratory particles, there's been some great work done. This is one of our fellow hospitals here in the Boston area, Boston Medical Center, and they've done some really nice studies looking with fluorescent dye with patients that are being intubated and coughing. And you can see this is just an example of some of these respiratory particles in the normal kind of intubating position. And this is somebody doing direct laryngoscopy on a mannequin. And so you can see they get respiratory particles all over their face. And so many of you might have seen in the New England Journal and other sources, the development of these isolation boxes to try to mitigate aerosolization. So with this, you can use still direct laryngoscopy and protect yourself, another layer of protection between you and the patient. We've taken things another step further here at the MGH, and we're actually looking at negative pressure isolation hoods. And so our COVID innovation team here and our Department of Anesthesia, Critical Care, and Pain Medicine have developed a couple of working models of these hoods. The idea being, if you can see here, that we have the hood hooked up to negative pressure suction. And this can either be wall suction or it can be even higher powered operating room suction, such that you would use during surgery. And we have a constellation of hand ports in the side. This model is really nice in that it actually retracts over the patient's head during surgery, and then you can pull it back down for extubation. This is a lighter weight model that we're also in development with that allows hand ports in the side. The idea with this being that we run into a lot of issues with aerosol generation. And so the issue with operating rooms, we have positive pressure in our operating rooms. So it actually will push virus particles out of the operating room. And that's normal for operating rooms to keep them sterile. And on our floors, we have a relatively few number of negative pressure rooms. Those are typically rooms that we use for patients with tuberculin type diseases. And so if you can create a localized negative pressure field, that's something that we can do to keep our patients and our people much safer. So these have been started to roll out into our operating rooms, and we're actually going to be bringing these to our intensive care units as well, because we're finding that we're actually have quite a number of aerosol generating procedures in our operating rooms, in our ICUs, things like trach masking, intubations, extubations as well. I'll touch on a little bit of the epidemiology of COVID-19. I think that most of us hopefully are aware of the Johns Hopkins Coronavirus Resource Center. This is one of the preeminent sources that we use here in the US to be able to look at coronavirus cases, mortality, penetrance into the local population throughout, sorry, one moment. Throughout our country. You can also see that it reports on countries throughout the world. And what we see here, I just pulled out one example from Central America, Mexico, reporting 9,500 cases. One of the issues with all the epidemiology data that we have is it's only as good as your reporting system. And so one issue that we come up with here in the US is that we don't test nearly as much as we probably should. There are some Southeast Asian countries that have done a much better job than us about being able to test vast portions of the population. In Italy, there are some areas where they're just blanket testing many people. And so as a result, you have to take all of these numbers with a bit of a grain of salt. There's also a lot of issues with government reporting, depending upon how the country wants to kind of look against other countries. You have different definitions of COVID deaths. There are some countries that are reporting deaths that are presumed COVID, others that are just reporting if they are COVID positive prior to death. So that can really change the numbers when we look at this data. One thing to note is that we can see, if we look at kind of the ramp up here, February, March, and April, it's been really a linear progression over the last month or two. And when we look at daily cases, there's a question as to, at least in the US, whether we're reaching kind of a plateau in new cases. That is yet to be confirmed, but certainly in certain areas, New York City is one of them, we are seeing kind of a tapering of new cases. Of greatest import to people in the audience and myself is these new cases that are being discovered still take a little while to develop disease, and certainly take even longer to present to the ICU and then have ongoing ICU needs. So it still is quite a bit of time, I think, before we see the end of this kind of surge in the epidemic. The really nice thing about this data is you can even go down. So this is Suffolk, Massachusetts. So this is the county in which Boston is, and this is where we are. And it can really give you granular data about your population, how things compare as far as ethnicity groups, confirmed cases, population-based statistics, which is really great. Again, I would just put the caveat that this is dependent upon how good your reporting system is. We're lucky here in Boston that we have a pretty good free flow of information, but we understand that that's not the case everywhere, unfortunately. Continuing on, this is some more granular data from here at the MGH. One thing that our hospitals in our system have been moving towards is giving daily updates to us to let us know how we're doing and kind of what to expect. So this is just a quick snapshot from a couple days ago here at the MGH, and it gives some numbers from the United States, Massachusetts, and then we can look at actually granular data with what we're seeing in our units and on our floors. And we're starting to see some good news. You know, we have patients treated to discharge, and that's a much bigger number than the patients that have succumbed to their disease. I'll talk about this a little bit later, but the majority of patients that we're finding that succumb to disease are elderly, have a lot of comorbidities, and oftentimes it's a withdrawal of care at the end. And so we're now getting this data very granular for each of our hospitals on a day-to-day basis. I'll touch on a little bit of the COVID pathology now. So some of you might have seen these graphs looking at COVID compared to both other coronaviruses and the seasonal flu. I like to talk about this, especially with my residents and fellows, because when we compare the COVID-19 coronavirus to prior coronaviruses, including SARS and MERS, we see a much lower fatality rate. Now, these epidemics have already gone, and so we have pretty good data surrounding those. We're undergoing a pandemic right now, so I think the fatality numbers are, still going to be a while before we understand exactly where they lie. But we do know that it's much higher than seasonal flu. With that stated, even with seasonal flu, I'm sure people listening to this call have had patients with devastating disease from the flu. We have patients here at MGH that die every year from the seasonal flu, and we have patients that are on ECMO support and other things as well. So not to downplay its penetrance, but just to put it in some context, the cases that we see in the hospital are the really severe cases. There are many, many more people that are suffering at home, and many that are probably not suffering very much at all and don't have many symptoms, but are able to pass it along through the community. And indeed, when you look at some of the good sources of data that we have, a study out of WHO China looking at kind of percentages of the population and what disease classification they were suffering from, the vast majority of these patients have mild to moderate disease. Very few actually have critical illness, and this is unfortunately taking up the vast majority of our resources in this time. Most of our hospitals aren't built for this type of critical care capacity, and so I'll talk about towards the end of the talk about how we've dealt with that here at the MGH. Of note, when you look at this, and this is some data out of Italy showing a pretty similar percentage of patients that require critical care, intensive care needs. The mild cases to moderate cases is what makes this a really challenging disease to take care of, because we know it has such penetrance in the community, and we know that people are passing it around because they don't know that they're sick. And we know that they can pass disease virions before getting sick, and then also with mild or no symptoms as well. So what is COVID? And I'm sure everyone on this call has read a bunch of papers on this and seen a lot of the reviews. Really, COVID is diffuse alveolar damage. As best as we can tell from autopsies from Wuhan and even some early data out of Italy and some early data out of the US in Seattle, what we see in looking at these pathological slides is destruction of normal lung parenchymal tissue. We see that the alveoli become thickened, there's hyaline membranes that are deposited. It doesn't look like our normal lung. And so the question being, how do we best treat COVID-19? Is it something that we can model off of other diseases that we're more used to taking care of? When we look at CT scans, we see diffuse ground glass opacities. Of interest, so this is a CT scan looking at the lung, and we can see white here being these ground glass opacities. So this is lung that's damaged. Of major interest to us is that there's a lot of regional distribution in these areas of diseased lung, and what we're finding is that there's a posterior predominance in many of our patients, and this is something we'll talk about a little bit later on with the ability to use some therapies like proning a patient, flipping them over onto their belly to try to recruit some of these anterior lung fields and get them better blood flow distribution, and hopefully bide some time while these posterior lung fields heal themselves. So the big question that we have is COVID-19 just ARDS? Consensus, at least here in the States, is yes. However, there's a lot of, I would say, academic dissent right now. There's some theories of some different phenotypes for these COVID patients, whether they're in a less compliant or more compliant disease physiology. However, I think hopefully we'll be able to show you in the next few slides that I think treating these patients like ARDS makes sense, at least for the vast majority of them. So what we know out of some data out of Toronto for the SARS-CoV-1 cohort of patients, and so this was the SARS virus that had, much like the MERS virus, is another coronavirus. They found in their data that lung protective ventilation has a significant mortality benefit. And all the pathological specimens, some of them that I showed you before, in addition to the SARS and MERS patients, are consistent with diffuse alveolar damage and ARDS. And we have that CT imaging that as well is consistent with ARDS. So I think most of us are familiar with ARDS, acute respiratory distress syndrome. The Berlin definition, which was developed in a consortium of pulmonologists, anesthesiologists, respiratory physiologists. This is one of their updates from 2012, looking at the kind of definition of ARDS. And one of the most important things in this debate over whether COVID-19 is ARDS or not, I think it's very important to understand that ARDS is just a symptom-based management strategy. We know that you can get ARDS from many, many disease states and from exposures. You can get it from autoimmune disorders. You can get it from volume overload. You can get it from pneumonias. You can get it from viruses. So it's really just a pathological definition and gives us some ideas on some management strategies. Most importantly, for the definition of ARDS, you have to have an insult. And I think for us, this fits with COVID-19. We have patients that have a novel coronavirus. Chest imaging, the bilateral opacities certainly are present on CT scan. And then making sure that the origin of these CT findings is not from cardiac failure or volume overload. And we're actually seeing very low rates of cardiac failure in our patients. So it seems to fit a lot of the definition. And then the hallmark of ARDS and ARDS management is kind of bucketing people into mild, moderate, and severe disease. And so what we can see here is that one of the things that we really look at in our disease population is the P to F ratio, or the PaO2 over FiO2 ratio. And looking at this in the Berlin definition, which I think helps guide us, at least here in our way that we treat patients with coronavirus, mild disease is 2 to 300 P to F ratio, moderate 100 to 200, and then severe is less than 100. And I'll take you through kind of how we think about this with our population. Again, when we talk about ARDS and that diffuse alveolar damage, here's a nice schematic that was came out of the New England Journal of Medicine, looking at a normal alveolar complex with type 1 and type 2 pneumocytes. You can see there's very little space between capillaries and airway, and you get nice diffusion of oxygen and CO2 across this membrane. And then when you have an injured alveolus, you have fibrin deposition, hyaline membranes, lots of activation of innate immune cells, release of pro-inflammatory cytokines. You'll notice a lot of these are targets of some of the therapeutics, IL-6, TNF-alpha, IL-1, leukotrienes. And what you see is you get inflammation, you get disruption of the capillary membrane, and you get an increased distance between the airspace and oxygen. And so you get lessened diffusion, and in this case, if you really have these alveoli that are full up of fluid and inflammatory processes, they're not really participating in ventilation. And so that's one of the hallmarks of ARDS, and this is what we're finding in our COVID patients. This is a nice graph just looking at increasing intensity of intervention by the P to F ratio, so breaking down between the mild, moderate, and severe ARDS patients. And of note, and something we're going to talk about throughout the talk today, low tidal volume ventilation is one of the most important things that we can do for these patients. PEEP titration, and then we'll talk a little bit later on about prone positioning. All right, on to some ICU management of these patients. I'll try to keep this pretty high level. There's a lot of data supporting what we're doing here that has gone back several decades. But to give you kind of the highline view, our management of COVID-19, we're assuming that these patients have ARDS, and certainly the preponderance of evidence suggests that that is the case. And so we really want to treat them as protective as possible. And so we do lung protective ventilation, and this is the ARDS net kind of level ventilation. So avoid volume trauma, too much volume in your lungs and breakdown of those alveolar complexes. And so we target 4 to 6 cc's per kilo of ideal body weight ventilation. We avoid barotrauma, and so we keep our driving pressures less than 20, ideally even less than 15 centimeters of water, and avoid atelectotrauma, or those alveoli and distal bronchioles from snapping open and closed, and that creates a lot of shear stress. And so we do that by optimizing our PEEP. And there's a lot of established best PEEP tables. We're lucky enough here that we have an entire team of pulmonary researchers that look at PEEP and do transthoracic pressures and manometry to help us establish best PEEP in these patients. And we do best PEEP trials on many of our patients. Of most import, I think there's probably a preponderance of evidence for certainly the low tidal volume ventilation, a little bit less data for the barotrauma and atelectotrauma, but really these are the hallmarks of how we take care of our patients. One of the challenges is that this is entirely non-physiological. And so we'll talk about some of the sedation requirements in the ICU, but this is not how we breathe normally. You know, most of us are breathing big tidal volumes at a slow rate and pulling negative pressure. So it's much different when we start bringing the ventilator in, and that creates some issues with sedation and kind of management in the ICU. Prone positioning is something that we found to be very effective, and actually now we're using it in patients that even pre kind of getting down to a PDEF ratio as low as 150. So we have patients up on our floors that are on nasal cannula or face mask oxygen that are actually spending time laying on their belly and in a prone position to try to increase their oxygenation and try to prevent them from needing an endotracheal tube and being ventilated. So once you're intubated and that PDEF ratio starts to get down into the 150 level, we optimize our mechanics using that lung protective ventilation strategy that we talked about before, optimize our PEEP, and then if you're still in the 150 range, we prone. And so there's a lot of data about proning. Here we do 16 to 18 hours a day. So practically speaking, we prone patients around mid-morning. Leave them prone and then supine them again the next morning, and then do another blood gas, look for a PDEF ratio, and then potentially reprone. We're lucky enough that we have developed a proning team. So there's a team of nurses and techs that actually roam around the hospital and help us with this because it is quite labor intensive. It takes between 5 and 10 people in the room to do these procedures safely. And of note, there's a lot of data on proning. A lot of it came out in the early 2000s. And really the only mortality benefit is shown if you do proning with lung protective ventilation. So that's our strategy here. We maintain that same lung protective ventilation that I spoke about here on this last slide, in addition to them being in the prone position. Paralysis is something that unfortunately we have to use quite often in our ICUs with COVID. We use it for prevention of dysynchrony and to allow us to do that lung protective ventilation strategy. Of note, there's been no mortality benefit proven through paralysis, so it's really something that we use as an adjunct, but it is not something that really is helpful mortality-wise and actually has some morbidity associated with it. As we all know, the longer you spend with paralysis on board, the weaker you get, the thinner your diaphragm gets, and the harder it is then when you are healing to get liberated from the ventilator. ECMO, that was kind of up here in this top region of the graph. So extracorporeal membrane oxygenation. Thankfully, we haven't had to use this very much in our patient population with COVID. I know that we're very lucky in the United States and certainly in MGH to have the capacity to put people on support, both VA, so venous arterial, and venous, VV ECMO. We haven't had a ton of patients that have needed this. It's in the kind of less than a dozen range. We've had only 1 or 2 that have needed VA ECMO, have needed cardiac support as well. But this is something that we actually have guidelines that we've produced for our COVID-19 pandemic, because these patients are a little bit different than our normal patient population that might need ECMO for kind of acute coronary syndrome or something else like that. All right, a little talk about some of the potential therapies, and I'll keep this very brief. There's, I would say, lots of talk and not a heck of a lot of data out there. And so this might be an area for future grand rounds if there's interest. Here's a schematic from JAMA looking at the SARS-CoV-2 virus, COVID-19, and kind of how its life cycle comes from when it first presents to a cell, when it gets taken in via an endosome, its RNA replication process, and then virion expression outside of the cell. And so what we see is that there's lots of targets. There's lots of areas that you could potentially target, everything from some of the pro-inflammatory cytokines that are released that create this inflammatory milieu, the receptors, including ACE2 receptors of note, that bind the coronavirus virion and allow it to be taken up into the cell. There's a lot of work on endosomes and acidification of these endosomes, making them less hospitable to virus replication. And then the different steps of virus replication can be targeted as well. The lower right here, we have some of the drugs that we're seeing here in the United States being used. Hydroxychloroquine, there's ongoing randomized controlled trials. Despite what you hear from government and lay press, it certainly has not been a panacea. Our patients are still extraordinarily sick even after getting hydroxychloroquine. Of note, we have seen many issues with QTc prolongation and arrhythmias. So this is something that's very important to be monitoring in these patients. There's looking at kind of co-infection using anti-inflammatory antibiotics like azithromycin, statins, which is something that has been trialed and really not very good supportive data, but aside from some muscle breakdown and things like that, and maybe some effects on the liver, it's pretty well tolerated in patients. So this is something that some centers are using quite frequently. ACE inhibitors, angiotensin receptors, again, the angiotensin 2 receptor is involved in the virion getting into the endosome. Our ongoing trials, remdesivir is a agent that inhibits the virus RNA replication. We have compassionate trial here, and we also have randomized control trials. So far, the data is somewhat promising, but certainly not a game changer. And then I'll let you read through the rest of these here. There's not a lot of supportive data. And then last is convalescent plasma. There are ongoing randomized control trials going on now down in New York City, and some case series with some promise. The big question with all of these is, are they going to help? And what we know from looking at prior coronavirus outbreaks, SARS and MERS, and also just ARDS in general, that no medications have been found that actually are very beneficial. It's really just waiting for the body and the lungs to be able to heal themselves, keep them from further damaging with low tidal volume ventilation, and really just excellent supportive care. Here's a breakdown. I won't go through all of these, but you can see this is just one snapshot of some of the therapeutic treatments that are being investigated kind of by location, and they really run the gamut. There's a lot of look at anti-inflammatory agents, mostly because we have these in stock from a host of different pharmaceutical companies. And so it's really easy. We have safety data to support their use. So we're kind of flinging a bunch of stuff at coronavirus right now. And I would say that right now, we haven't seen anything that has been a very significant effect. And the other thing is that, most of these agents have been tried for other disease states and haven't been found to be terribly beneficial. So I think the jury is still out on these. All right, so I'll spend some time now talking about lessons learned about how we manage our ICUs, and a little bit about using anesthesia machines for ICU patients, as I know that's been one of the questions that has been brought up before this talk. We as anesthesiologists use anesthesia machines and are used to taking care of critically ill patients. For those of us that are ICU trained, this is very normal. For those that aren't ICU trained, many of them are being given promotions and are now taking care of these patients. And so hopefully if we can discuss some of the issues that we've come over, we can help everyone and hopefully have an open dialogue going forward. So we have a number of ICUs here at the MGH. We're lucky enough that we have about 1,000 beds here at any given time. This number can kind of go up and down depending upon our need. And during normal times, we have about 150 ICU beds here at the MGH. So we're a big hospital. We're much bigger than a lot of hospitals out there. Certainly a lot of the community hospitals here that might only have about 10 ICU beds. So we're a behemoth compared to many. We have medical ICUs, we have surgical ICUs, we have mixed ICUs, we have coronary and cardiac care units. We have cardiac surgical ICUs, pediatric ICUs, neonatal ICUs, burn ICUs, and then specific neuro ICUs. So we have lots of ICUs, and we're lucky with that we have lots of intensivist physicians of many different training backgrounds, which is very beneficial to us. Just to give you an idea of what we're going through now, and if you remember from my earlier slide, at any given time now, I think as of 2 days ago, we had about 165 patients with coronavirus in our ICUs. And then we also have other ICU patients that are COVID negative. So we've had to expand our ICU coverage. So we have about 119 new ICU beds that have been added so far. And what we can see here is that most of these areas have been in the PACU and 2 of our general medicine floors. And it's been really amazing to see the progression of these in just a few short weeks. We've been able to develop these areas, and they really feel like ICUs. So right now we have about 269 ICU beds available to us. There are plans for what we need to do in the future if we need to open this up to other areas, other floors of our hospital. And then one kind of hot topic for us anesthesiologists is, would we use the ORs? And it's a very complicated issue. ORs are designed for one patient at a time in one area, and so it would be heavily resource intensive compared to how we normally take care of ICU patients in a more open floor area where you have several providers providing. Speaking about ventilated patients, so during normal times, we have 50 to 60 of our 150 ICU beds taken up with ventilated patients. And you can see some of the machines that we're using right now when we have greater than 165 ICU patients that are being ventilated. So what we can see here on the left is a normal ICU ventilator. We have travel ventilators. These are small handheld ventilators. You can see this is a handle to fit your hand in. So these are very small vents that we use when moving patients around the hospital normally, but we're now using these to take care of patients long term. And then we have our anesthesia machines that we're lucky enough to have very many of here in the MGH. And so we've been deploying these now, and I'll talk a little bit about the use of these OR ventilators in the ICU. One of the most important things to realize about these ventilators are there's variable expertise in the use of them. We're used to in the ICU using the ICU ventilators that have respiratory therapists that are experts in their care. Some of these other ventilators our respiratory therapists don't have a lot of experience with, and indeed we're kind of stretching our respiratory therapists. So we've had to recruit other people to be able to use these ventilators, and I'll talk a little bit about that. One big difference between our management here in the US and at the MGH compared to what you might see out of the data coming out of China. We use actually very little high flow nasal cannula or BiPAP in our patients, mostly for aerosol generation issues and the heightened risk. And so we actually are much quicker to go to intubation to try to keep our people safe and decrease the viral load into the environment around these patients. So a little bit about the anesthesia machine. So as we all know, for those anesthesiologists on the call, this is, we're lucky to have Draeger Apollos here, but regardless of what anesthesia machine you have, we're used to these heat and moisture exchangers. These are really great and they work beautifully during surgeries for, we do surgeries up to a day. However, when you have a patient that's in the ICU, these start to get clogged very quickly. And so we've had a lot of issues with needing to change out these filters a lot more frequently than we first thought. There are also separate viral filters that we'll put on our machines. And so our typical setup is to have one of the heat and moisture exchangers, which is a viral filter in and of itself at the distal end right by the Y piece, and then a viral filter protecting the machine more proximally as well. One big difference between anesthesia machines and ICU machines is that you, at least for these very advanced anesthesia machines, you really can't clean the inside of the machine. So you really want to keep any virion particles from even getting close to the internal airway and pathways and valves that are in our machines. So as I mentioned, we have many different types of ventilators, and our respiratory therapists are really being stretched thin with the number of patients on vent. So we've had to design some different ways of doing things. The other thing is that on many of our floors, we don't have the same ICU monitoring that we're used to. So whether it's overhead alarming, many of the areas don't have that capacity. And certainly when you start to get anesthesia machines or vents, they might not hook into the system and allow for central alarming. So we actually have some floors where we have physical alarm monitors that sit outside of the rooms and kind of raise a hand and flag people down if they see an alarm inside the room. We're lucky that some of the areas that we've been able to flex into have been PACUs or recovery areas, and so we've been able to utilize those central alarms, and to really good effect. Oh, sorry. So some of the challenges that we've had with our ventilators, staffing, as I mentioned, the respiratory therapists don't have a lot of knowledge in this area, but we're lucky that we have lots of anesthesiologists around. So we're using our attendings, fellows, CRNAs, and residents to manage these machines in our surge ICUs. Of note, we're finding some big differences between ICU vents. They're designed kind of with flow by. They're very gentle. They tend not to alarm too much, even if a patient's a little bit desynchronous or breathing against the machine. Our anesthesia machines, whether they're pistons or bellows driven, really just like to do one thing. And so they have really high sensitivity. They're used to having somebody within arm's distance of them to clear all of those alarms every few seconds during surgery. And so it's a little bit different way of taking care of these patients in an ICU setting with these machines. Of note, these patients in the ICU really have, for the most part, isolated respiratory failure, at least at the beginning of their treatment, and sometimes can go into more multi-system organ dysfunction going forward. So we make sure that we keep them on lung protective ventilation. And as I mentioned, that's really non-physiological. These patients don't like it, and so we need to have really high levels of sedation required. You'll notice all of these medications that are are used throughout ICUs and ORs. The one interesting thing that we're able to use, since we are using anesthesia machines in some of our units, is inhaled anesthetic agents. So we've started using isoflurane for a number of patients and being able to peel off a lot of the GABAergic agents that we use in our ICUs. And unfortunately, because of dysynchrony and just from disease pathology, we see a lot of paralysis and proning in our units. So some of the practical lessons, there's a lot of bacterial co-infection that we're treating our patients for. We have a really low threshold for antibiotics. Our community-acquired pneumonia coverage here for the bugs that our patients are exposed to is ceftriaxone and azithro. If they have a healthcare-associated pneumonia, or if it's a ventilator-associated pneumonia, we go to vanc and cefepime. We do send procalcitonins on a lot of these patients, and we get ID involved early on so that we can have as best antibiotic stewardship during this time. So intubations, I've kind of touched on some of this before. High flow nasal cannula and BiPAP we're using a lot less. It's not in our best practice, at least currently, because we're trying to lessen the amount of exposure of our staff and other patients. I think most importantly for determining when to intubate somebody is not just their kind of total oxygenation utilization, but also what their progression of oxygen needs are. So if we have somebody that's even on pretty limited oxygen support in the 4 to 6 liters per minute range, but if they're working hard and they're kind of progressing, we are intubating these patients much earlier than we normally would. And one of the goals of the early intubation is to make sure that it's elective, so it's not an emergency situation, and really to keep everyone safe and to keep these patients from further injuring their lungs. Some of the other issues that we're coming up with and finding out as we take care of these patients, ileus is something that's a very big practical concern. We've been doing early enteral feeding, aggressive bowel regimen, and we've actually had a number of our patients with issues with bowel obstructions, ischemia requiring surgical management. Coagulation is something that's been a hot topic in the lay press and in many of our scientific journals. It goes back and forth with us right now. We initially had a pretty high incidence of coagulopathy. Now we give everyone prophylaxis, some of our patients with increased prophylaxis, depending upon what their coagulation studies tell us. And we are seeing DVTs, PEs, and probably microthrombi in the lungs that we're treating with therapeutic anticoagulation. And even some patients have arterial and central line clots, for which we're now using much more heparin and TPA than we ever did. So there seems to be something either with the pro-inflammatory state of COVID or the urine exposure itself that leads to some coagulation and coagulopathy issues. Acute renal injury is quite common, probably because we fluid restrict these patients so very much and try to keep the lungs as dry as possible. There's this question of whether it's an intrinsic effect of the virus. We have overall a fairly low incidence of percentage of our patients that need CVVH, so continuous venous hemodialysis or regular hemodialysis, certainly compared to our normal septic patients, but we have a whole lot of these patients. And so it's really starting to overwhelm our renal replacement capacity. Certainly in areas that have been hit harder than us, this has been a rate limiter even more than ventilators sometimes, is being able to treat renal failure in these patients. We don't really see a lot of distributive shock in these patients. It's probably a combination of sedation and co-infection, but that actually has been something that we haven't luckily had to deal with very much. And cardiogenic shock, there are reports of viral myocarditis and also stress cardiomyopathy, Takotsubo's like cardiomyopathy. We get troponins and lactates and all of the normal parameters that one would get. We also have a lot of bedside echocardiography that we use to assess cardiac function. And so far, we've only had one patient that's needed VA ECMO support. So it seems like the vast majority of these patients we're keeping from progressing down this kind of distal pathway. So other things that we're doing in the ICU is we're limiting a lot of the things that we would normally do. So, and this is to limit the usage of our PPE, our personal protective equipment, and also exposure of our staff and our other patients. So we try to bundle procedures as often as possible. We do our intubations, we put in central lines and arterial lines all in one process instead of coming in and out of the rooms. We're also not getting the routine chest x-rays. We're not bronching people, getting echoes and CT scans like we used to. We still get these studies when they're indicated, but kind of the routine ICU level care of getting these on a routine basis we're not doing. And then the other interesting thing that we're going to be finding, I think, more and more is that these patients require ventilation for a prolonged period of time. And so we have tracheostomy plans, and right now we're looking at about the 14-day time period. In one of my units yesterday, we did 4 trachs out of 18 patients. So we're definitely moving towards that in a lot of our patients. I think, you know, in 5 to 10 years, we're going to see what the ramifications of this on kind of tracheomalacia and tracheal stenosis, and we might have ourselves with a lot of patients that are needing tracheal reconstructions in the future. Extubations, we have a really high threshold for extubating these patients. Unlike normal patients, there's issues with both, having virions expressed into the atmosphere with aerosols. So we really take a lot of care before extubating these patients and make sure that we can kind of limit our exposure as best we can. We're also seeing a high incidence of airway edema in the para-extubation patients. So we are giving corticosteroids for many of these patients. We think most likely due to just the prolonged intubation of these patients. All right, we have about 10 minutes left on my clock, so I'll take you through a quick little recap and hopefully have time for some questions. So this is our MGH treatment guideline for critically ill patients, and this is a living document that we refer to on a day-to-day basis and gets updated. This really, my entire talk can be summarized on this one sheet of paper, and it goes through kind of presentation, the diagnostics that we look at, monitoring, some of the testing that we do, what to do for hemodynamics, kind of the usual care things that we're now no longer doing, some of the things that we have a higher threshold for, bundling those bedside procedures, what we're doing for all ICU admissions when it comes to some of our investigational trials, and then kind of the pathway that we talked about, which is early intubation. We're avoiding high flow and non-invasive BiPAP, lung protective ventilation, conservative fluid strategy, PEEP titration, early proning if needed, additional therapies for patients that are desynchronous, and then kind of the hallmark of this, which is patience. I can say from taking care of these patients for the last month or two since we've had our COVID patients be with us, it's very humbling taking care of these patients. They are really, really sick for a really long time. And so mostly we just have to wait it out and allow time for their lungs to heal. So with that, I'd like to thank you all for having me, and hopefully I can answer a few questions.
Thank you so much, Dr. Ryan. I would like to know if there is anyone with a question. You can chat it, and I will say it out loud for the doctor to answer. So far, I'm not seeing any questions. So, is there anyone who would like to know something else? Igual, si tienen alguna pregunta, la pueden chatear y con muchísimo gusto la comparto al Dr. Ryan. Okay, we have a question. So I'm guessing that was a very clear presentation.
Well, in that case, thank you so very much for all of your time. And I think this is a really incredible opportunity that you and the consortium have gotten together to give back to all the clinicians taking care of these patients. I would say the more open dialogue that we can have between clinicians across the world who are taking care of these patients, number one, the safer we'll be able to keep each other and the better outcomes that we'll have with our patients. So thanks so much for having me, and hopefully we can speak more.
Thank you so much, Dr. Ryan. And I'm sure I'm speaking for a lot of us that we would love to have you here again. Awesome. Also, thank you to Richard Boyer, who is the founder of COVID Challenge, he told us that we should talk to you. Now I know why. And of course, Jonathan Nelson from HackFund and his entire team for helping us do this. So thank you so much, and we hope we have you here again.
Thank you so much. Have a great day. Stay safe, everybody.
Thank you. Have a beautiful day.